Good evening, sir.
Rohan?
Good evening, Amay sir.
Good evening.
Good evening, sir. Rohan, you will try calling Kiran sir once. He's just cutting my call.
I'll give him a call.
He
Yeah.
is busy in ABCDI.
Oh, okay, okay. No, sir, I had spoken to him. He had said yes. But I think, yes,
It must be a Q&A session going on right
Okay,
now. So
okay.
that's why. He'll come.
Sampath ma'am has joined.
Yes,
Hi, ma'am. Yes, ma'am.
Good evening, madam.
Good evening, ma'am.
Madam.
Hello, Sampath. How are you?
Amaya sir, good evening. Hi sir, good evening. I am in Trivandrum, sir, in a CME.
Yeah, good. Hey, how are you?
How are you,
I heard you are not well, a little bit flu or something.
Not flu, sir, throat infection. I went to TNFOG, Kodaikanal.
Okay,
Throat
okay.
is like that. No
Okay.
flu. No flu should come for 52 days. After 52 days.
Please take the vaccine.
Sure, sir.
I just took the Shingrix vaccine second dose today.
I will take, sir. Definitely.
So all people above the age of 60 should take it.
Sir, take Dolo 650 immediately.
It's actually it's not like
No, it's not the pain, sir. You will feel feverish at night or tomorrow morning. This is very normal.
I took it yesterday, so
yeah.
I'm okay.
Nowadays we are recommending you take the Dolo 650 within 6 hours of the vaccine.
Okay. But already I have started, Amaya, so I will have the vaccine. Dolo 650, I have already started. Tomorrow I'll have
No, I am telling sir.
Sir, yes.
I had taken the shingles vaccine. In fact, the GSK had offered during my presidency that they had offered that they'll give this concession to all the gynecologists if they take the vaccine. And then recently, in the last 1 year, 2 of our relatives had herpes zoster, one in USA and one in India, and they made so much severe pain they had that 2 months it was horrible. So I said better, and when I yesterday took the vaccine, I was in the Lilavati consultants, and they said, "Oh, Dr. Pai, why did you take the vaccine? You have got the chicken pox already. You don't need to take." Then I was a bit puzzled. Then I asked Claude. I said, "Claude, am I taken the vaccine by mistake or something?" He said, "No. In fact, if you had chicken pox, the virus is sitting dormant. It can infect you. There's a higher chance that you will get infected. So you must take the vaccine if you have had chicken pox, because the vaccine, the virus can get activated and the pain can be more severe." So I was happy that I didn't waste my vaccination.
Yes, sir. It's better to have. We'll have. Yes, Madhumita and Sparna, we can start the program, I think.
Yeah, Madhumita, you can start, I feel. Everybody, even Kiran sir has joined.
Kiran sir has
Kiran
joined.
sir has
Guest of
joined.
honor.
Yes,
Kiran sir
yes. All our guest of honor and chief guests have joined.
Yes.
Sure.
Sahiti,
Yes.
can we start?
Yes, ma'am. Yeah. We are live now.
Shield connected.
Yes.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, TNFOG with AMOGS Societies. So let us start the webinar with Saraswati Vandana. my privilege to introduce the conveners of today's webinar, Dr. Pradnya Supe ma'am. Ma'am has done fellowship in laparoscopic surgery and also consultant in obstetrician and gynecologist and laparoscopic surgeon and lactation consultant. Ma'am has been attached with Surya Hospitals, Gen Hospital. I welcome you, ma'am. And it's my pleasure to introduce the other convener, Dr. Madhumita Arun Karthik ma'am. Ma'am is the consultant obstetrician and gynecologist from Salem, National Coordinator of Midlife Management Committee, FOXY, South Zone and TM State Coordinator, FOXY Presidential Activities 2026. I welcome
Thank
you,
you,
ma'am,
Sahithi.
and I
Yeah.
hand over the session to you.
Pradanya ma'am, you will introduce Sampath ma'am.
Can I
Yes.
please have ma'am's
Sahithi,
CV?
please. Sahithi, can you
Yeah. So it's an honor to introduce Professor Dr. S. Sampath Kumari ma'am. Ma'am is Professor and HOD at Shri Muthukumaran Medical College. Madam is Foxy Vice President 2022. I'm proud to say she is a national corresponding editor of Jogi, founder secretary of Tamil Nadu Federation of OBGYN, immediate past president of OGSSI. So Madam, please, I request you to say a few words to start this webinar.
Sure. Thank you, Pradnya. See, I thank Dr. Amaya and Dr. Rogan for accepting to have this webinar TNFOG with AMOGS. And I welcome the chief guest, Dr. Amaya Purandare and Dr. Rishikesh Pai sir, and the guest of honor, Dr. Kiran sir and Dr. Rogan. And we have the wonderful talk on fetal medicine, preferably today. We have the topic on AA and ultrasound by our Dr. Suresh, and chairing person, Dr. Rai. We have the panel on by the Dr. Chinmaya Ratha, and the panelist being Dr. Anil, Dr. Manisha, Dr. Saira, Dr. Revati, Dr. Nivedita, Dr. Preeti Vyas, Dr. Nipur, and Dr. Sankita. So this is a real opportunity for the TNFOG and the AMOGS to combine and do this program. And I should thank Dr. Pradnya who took efforts to make all the people come here, and our MOC, Dr. Madhumita. We can start with the program. I request our chief guest first, Dr. Amaya Purandare. Yes, in the starting, I would like to tell that I am contesting for Foxy President. All of you, please vote for me. Yes, Amaya CV.
Madam, it's okay. No need for the CV.
He's the
It
president
gives-
of AMOGS. Yes, Amaya.
Yeah, it gives me great pleasure to be here as chief guest in my capacity as President AMOGS. In AMOGS, we strongly believe that we have to spread the reach of AMOGS, not just in Maharashtra, but beyond Maharashtra. And that's why we are collaborating with all the state organizations. And I'm thankful to Dr. Sampath Kumari, who has come forward for joining hands with AMOGS with the TNFOG. For me, it is a special evening today because two of my inspirations are sharing the stage with me. Number one is Dr. Rishikesh Pai. Dr. Rishikesh Pai is my true mentor, and I call him mentor because he's always encouraging me and he's always there giving me the confidence to achieve more in my life. So thank you, sir, for being here. The second person is Dr. S. Suresh. For him, I am Eklavya. The reason I say this is because more than 30 years back, I visited Mediscan system after being the chief convener for the Wadia ultrasound course for more than 10 years. And sir remembers that he asked me in his morning 8 o'clock lecture with all the trainees that why you are here. Because you are already running the successful Wadia ultrasound course. I said, sir, I'm running the course, but I have never been trained myself because I'm just observing others. So then we were taken for the sessions to see people performing ultrasound, all his trainees, fellowships, fellowship students, VG ma'am, etc. at his Mediscan system. And next day morning, he said, there is one person who is different in amongst all of you. And that is this boy, Ameya. So I was little worried. I had done some mistake. So I said, sir, what have I done wrong? So he said, all the other people are looking at the monitor what they see as the image. But you are not looking at the monitor. You are looking at my hand, at the probe, how the probe is moving to get that image. So I said, sir, because your probe is like in today's context, like AI, it will achieve the final result. I know what is going to be seen because I was training people to see that again and again. I wanted to see whether my hands move correctly to achieve that. So this was the impact of AI 25 years back. I'm really happy that sir is going to be talking about AI. He is really a person who adopts technology for the benefit of his patients. And I'm thankful that all the AMOGS delegates, the TNFOG delegates, and all the delegates from all over India who are attending here will benefit greatly from his talk. The second faculty that we have today is Dr. Chinmay Ratha. Dr. Chinmay Ratha is the modern version of Dr. Suresh because she is always wanting to be friends with Amoxians, and she's always making complex situations seem very easy. So thank you, Chinmay, for being here and moderating a panel on a very complex subject of what to do when you have borderline findings. My special thanks to Dr. Kiran Kurtakoti for making it here this evening. The reason is because we are running the ABCDI course and Kiran is very passionately running it as the Maharashtra College academic coordinator. Kiran, I'm sure that we will have to look at AI sometime or the other in our academic ventures. And Dr. Rohan Palshetkar, my secretary at AMOGS, for being here today and running the organization very smoothly from both the administration and the academic part. Special mention to Sampat Kumari Madam. Wish you all the best in your endeavors. And to Dr. Pradnya Supe and to Dr. Madhumita. Madhumita, wish you all the best also. And Pradnya, you are already doing excellent work at MOGS, at AMOGS, and Foxy. And I just met your father yesterday in the flight. And I said that the future is very bright for Pradnya. So thank you all. I'm sure that we will have much more collaborations. And indeed, it is a special evening this year to be with all of you amongst all these special and legendary people. Thank you once again.
Next, we have our Dr. Rishikesh Pai sir. As Dr. Amaya told, Rishikesh Pai sir is my mentor. I was the vice president with Dr. Pai sir as the president, and he will never interfere with anything. Whatever you want, you do it. So that is the personality of Rishikesh Pai sir. Whatever work he told, he will take 5 or 6 people with him. So I think everyone needs introduction. Pai sir was the past president of the Foxy and past president of the AMOGS and the chief administrator. And this Manyata program, really it is now the most of the hospitals in Tamil Nadu, they have this Manyata accreditation. So he is the chief administrator in Foxy Manyata project. Now we will have words from Dr. Rishikesh Pai sir. Dr. Pai sir.
Thank you, madam. I would like to thank Dr. Sampat Kumari of the TNFOG and Dr. Amay Purandare of the AMOGS for inviting me here today. And, of course, I would like to pay my respects to Professor Suresh, who is a great personality, a big asset. And we are all proud of you. He is one of the gems of our medical fraternity in our country. And of course, Dr. Rohan is now the dynamic secretary of the AMOGS and chair of the YTP committee of Foxy. And I'm sure he's going to go a long way. And Kiran Kurtakoti, our great AMOGS president, past president, is now taking care of her college, Maharashtra College. And then we have the conveners, Dr. Pradnya Supe, who is very dynamic, and Dr. Madhumita, who is also very active, and wish you all the best. Of course, Sampat Kumari, I must say, one of my very active vice president, very dynamic person, did a fantastic job during my tenure as, Foxy president. We did the Yuva Foxy in the Kodai Canal. We went to Andaman Islands. She came with me to UK. We did the Southern Yatra of anemia was totally done under her leadership. nearly that time we covered 20 cities. Imagine what of like, I sometimes I feel I should do it again with all of you. So, it's more fun to do things when you are not in power. And that's when people appreciate it more. So anyway, I was thinking in my mind, my very like to do it in November end and December, go through the plains of the north again and enjoy it. And of course, there are a lot of other Chinmayis there and a lot of other dynamic personalities. Artificial intelligence, when we were in COVID times, I started reading it a lot. And one of the first people to bring our Bloom IVF group is one of the first to bring AI into the country in IVF lab. We did the embryology AI we brought the AI for oocytes. And recently we have just ordered the AI for the sperm as well, which will get installed in our clinic. And of course, there is a lot of new AI that has come in ultrasound, which Dr. Suresh will talk to you about. So the very exciting news in the AI industry is just what was announced 5 days back, that the new the new laptops are coming with the AI. The laptops are going to cost around 3 lakh to 4 lakh rupees, 2.5 to 3 lakh rupees. And most of the work will be done by the agent within the laptop. So you don't need an internet connection. So that particular is called edge AI. So when the AI chip is inside the machine, and most of the ultrasound machines, the NVIDIA chip will get implanted now in the machine. I don't know whether it's already there or not, but the edge AI will come, so you don't need an internet connection. So even if you have a handheld, so for example, POCUS, you can just go to the village, and the chip, if it is embedded in that, it will give the report immediately. So it's going to be a big advancement in all fields of medicine. So I'll not take much of your time. Wish you the very best for this program, and we looking forward to a very interesting information coming in. I always believe that you should keep on listening to people and get more information. And of course, before I wrap it up, the quantum computer is on the way now. So the quantum computer has got installed in first quantum has come to India already, and that the speed of the quantum is much more higher than the AI. So you imagine with the quantum, a lot of breakthroughs will come in medicine very, very quickly. So a very exciting future ahead, and maybe if the breakthroughs come in maybe our longevity will go up. So I feel that if we survive for 5 more years, then all of us oldies will survive for 80 more years, because the breakthroughs will start coming in rapidly in anti-aging area. So thank you for calling me here. Thank you.
Thank you, sir. Thank you, sir. You will be there till definitely, sir. Thank you so much, sir. Now, I request Dr. Kiran Kurte, sir. He was the past president of the AMOGS and
Dr. Sampath, it's
ex-chairperson.
okay. Dr. Sampath, it's
Dr.
okay.
Kiran. Yes,
No,
sir.
it's okay.
Dr.
It's
Kiran.
fine. Today's chief guest, Dr. Ameya Purandare, my close friend, Dr. Rishikesh Pai. As a matter of fact, I have been listening to Rishikesh. Rishikesh was the first person whom I listened to. Whenever he talks, he brings something new. So the first talk that I listened was this embryoscope. So that was the first embryoscope which they brought to Leelavati in India. And then whatever his talks on AI are there, they are just fantastic. I mean, he is a visionary leader. And I think every time I listen to Rishikesh, I hear something new. Last about 5 years back, he spoke about CRISPR, and then now CRISPR is a reality. So thank you, Rishikesh, for that also. My co-guest of honor, Dr. Rohan Palshetkar, and of course, at the outset, let us clear everything. That at the outset, will be wishing my best wishes to Dr. Sampath, because she's going for the post of the president. So my best wishes to you. My best wishes also to Madhumita. Madhumita, I know you have a long innings ahead of you, and of course Prajna doing a fantastic work for AMOGS, and I'm sure that shortly she will move up to the national screen. So thank you, Prajna, for that. I see also Rachna and of course Dr. Manisha, our favorite AMOGSians, and my close associate Dr. Renuka Pathak of Ahilyanagar Society. So hi everyone, Rohan, hi everyone. Now in Hindi, there are certain songs which you keep on listening, and if at all you listen to the song, you automatically start humming. You are not tired of those songs. It is like our Janagana Mana. So similarly, Dr. Suresh and Dr. Chinmay, these are the people I have been listening to, sir. Sir, so I had been to Chennai. Me and my wife were in Chennai. So my wife was with Dr. Suresh for about 3 months or so. I was with him for 15 days, 20 days, and then I moved on to Korean for my training. And we also use this Mediscan software also. So I mean, whenever I listen to Dr. Suresh, it is like Veena playing. So I have done so many courses, so many courses. I have done the Thane ka course, I have done the Nagpur ka course, and each and every talk of sir, I have attended practically 3 or 4 CUSP conferences also. So every time we go there, he's a doyen of ultrasonography, and Chinmay, of course, you are there on our AMOGS platform many times, and we are sure that you will be visiting us shortly also. So thank you so much, and I'm sure that I look forward to listening to Dr. Suresh sir. And one small request to sir is please incorporate that AI model in the Mediscan system software, so that we don't have to send our patients to a fetal medicine consultant for doing the NT scan and double marker. That is a humble request. And I'm sure with you and the help of that software, you can definitely integrate AI in Mediscan system software. So with this short ado, please get on with your talk, sir. Thank you, sir.
Thank you, Dr. Kiran, sir. Thank you so much. Dr. Rohan?
Yeah, madam. Thank you so much.
Yes, I'll introduce Rohan.
Madam, it's all right, madam. I think we've got too many doyens for me to be actually introduced here.
Yes, sure. Yes, Rohan, you are the signal.
At the outset, madam, I just want to wish you all the best for the elections, and I hope everything goes your way. I want to first just acknowledge the presence of our chief guest, Dr. Amay Purandare sir, the president of AMOGS, Dr. Rishikesh Pai sir, my teacher, my mentor for all the things that I know in IVF, Dr. Kiran Kurtakoti sir, the immediate past president of AMOGS, Dr. Suresh sir, we've been hearing you for so long. It's going to be a pleasure to hear you again. Chinmay ma'am, what can I say? It's more of a friendship. I'm like her younger brother. I don't want to call her my older sister. I want to call myself the younger brother rather than that. But I just want to say one thing, that the collaboration that ma'am that you've thought of, each of us have are experts in our own fields, but our experiences across the states really makes a difference. So I'm so glad that we're going to get an experience as well as evidence-based fetal medicine along with AI to actually understand what we come across in our day-to-day practice across the states. I also want to congratulate the conveners, Dr. Pradnya Supe and Dr. Madhumita, for curating such an amazing program, because these are topics which are interesting for all the delegates who are logged in, and I think it really makes a difference to the delegates in their day-to-day practice. And I think you'll have chosen the perfect speakers, the perfect moderators, and the perfect panelists to actually ensure that people are taking home great messages. So I don't want to take up more time. I'll hand it over back to you all, and I'm really looking forward to the program today. Thank you very much.
Thank you, Dr. Rohan. See, as all of you told our Dr. Suresh, we cannot match with Dr. Suresh. Only one thing I want to tell is, Dr. Suresh did his MBBS in Chengalpat Medical College. In the same college, I also did the medical college. That is the only one point I can correlate. Dr. Suresh. Anyway, welcome, Dr. Suresh, sir. And thank you, Dr. Ramya, Dr. Rishikesh Pai, Dr. Kiran, and Dr. Rohan. Madhumita, start with the scientific session.
Moving on to the first session. So we have a very interesting talk on AI in ultrasound by Dr. Suresh. Pradanya ma'am, will you be taking over, ma'am? Introducing our chairpersons? Yes.
Sure. So our first chairperson for today is Dr. Renuka Pathak. Madam is consultant obstetrician and gynecologist at Swasthya Medical Hospital. She is president Ahmednagar Obstetric and Gynec Society 2025 to 2027. Welcome, ma'am. Great to have you here. Our next chairperson is Dr. Vinayak Khedekar. He is president Aurangabad OBGY Society. Welcome, sir. And our third chairperson for today is Dr. Rachna Jaju, who is a practicing gynecologist for last 10 years, member of the PAC committee of AMOGS since 2022. She is currently the chairperson of the AMOGS Safe Motherhood Committee 2026-28. Welcome, Dr. Rachna. I now request our chairperson, Dr. Renuka, if you could introduce Dr. S. Suresh sir. Sir obviously doesn't need an introduction, but still.
Yeah. Thank you very much, Dr. Pradnya and Dr. Madhumita, for inviting us. It's indeed my real pleasure to introduce the great Dr. Suresh sir. It is my fortune that I met him last year itself. He had come down to Ahilya Nagar to deliver a lecture, and it was really a very good experience. Sir, as everyone knows, is the director of Mediscan Systems Chennai. He is the director of Media Logic Solutions India. He's the director of the Surendra Genetic Laboratory Private Limited, Chennai. He's a clinical director, Perkin Elmer Health Sciences Private Limited. Adjunct professor to the Tamil Nadu Dr. MGR Medical University. Member Subcommittee Health Tamil Nadu State Planning Commission. Project Director, Mediscan State Health Society, training the medical officers in basic obstetric ultrasound in the NRHM Chennai. Honorary Secretary, Voluntary Health Services, Adyar Chennai. President, IFUMB from October 2014 to 2015. 33 years of experience in ultrasound and a doyen in his field. Sir, we welcome you for this session. We are looking forward to AI in ultrasound and listening from you.
Thank you. Good evening to all. First of all, thank you very much for inviting me. And I thank all who have spoken some nice words about me. I'm quite amazed that Amaya remembers every single word that we said more than 2.5 decades ago. And it's now 44 years in ultrasound. I become much older now. But what's happened over the last few years is artificial intelligence is slowly creeping and changes are happening almost every week. And many of the AI algorithms have been incorporated into ultrasound machines. But I would just say it is just the beginning. So let me take you through some aspects of AI in ultrasound. So AI actually started in the early 50s. And it's remarkable it has taken so long. But in 2019, 80, 90, the word machine learning came up, where the machine learning, the machine is able to learn from when it was trained. And then you have deep learning, where neural networks were formed and the machine was not only able to, we were able to train it, but it was also able to make some logical decisions. So almost like the human brain does. So the word artificial intelligence is a type of advanced technology that mimics human intelligence. And remarkably, it is the human intelligence which made this artificial intelligence. And very soon that may become the primary intelligence as we go by. Machine learning is a subset of AI that learns patterns from analyzing large amount of data. And that's how ultrasound, it learns from those images. And deep learning is a subset of machine learning that uses neural networks, as I said earlier. So what's happening here? There is reasoning, there is learning, there is adaptation, relearning, then sensory understanding, then there's interaction, and then the systems become better and better over a period of time. So deep learning actually simulates the biological brain. We give an ultrasound image and we call it as the input layer, and we provide what we call as, we mark it, and from the data, you're putting these points, marking them, and this is called as annotation. You annotate hundreds and thousands of images and then give it to the machine and tell you, this is the nose, this is the eye, this is the palate, this is the leg, and very soon it starts recognizing that. And the output layer, what happens is it tells you the leg should actually look like this, but this leg is not looking like that. So possibly there's an anomaly. And but it all started with voice recognition. When you voice recognition, what happens here? Here's an ultrasound machine.
Depth increase.
So somebody's talking to the
Depth
ultrasound machine.
increase. Depth decrease.
And it is responding to all the
Depth
commands.
decrease.
Which means if you're doing an interventional procedure,
Color mode.
you don't need somebody standing by side of the
Color
machine
mode.
touching the buttons. All button commands can be
Freeze.
given by voice.
Save image.
And this is what is available in our phones also, like Siri.
Depth increase.
Right. Now, when you move to AI in ultrasound, we can have automatic recognition of image planes for image capturing and for image audit. And I'll come back to that audit, which is very important. Then we have automatic biometry and also detection of abnormalities is the way we are going forward at this point of time. So what is the challenge of ultrasound images? It is training the AI system because in the ultrasound image, it's real time and you can see the same head in the axial plane, in the coronal plane, and also different levels of transventricular plane, transthalamic plane, so on and so forth. And the machine has to be told that these are the part. This is cavum septum pellucidum. These are the two thalami. This is the lateral ventricle. All that machine has to be told during the training. And when you train the system, it has to be trained with the perfect images. And there should be agreement between multiple experts. And we find the algorithm matures over a period of time. And that's why the need for big data of what we call as the ground truth. The ground truth actually means I'm saying that this is the choroid plexus, and how sure are we that that is exactly the choroid plexus? And if you tell the truth to the system will learn the truth. So it's all about training. Now, here is a equipment where I'm going to do a targeted scan. I'm moving the probe, and as I'm moving the probe, it's automatically recognizing the planes and it is capturing on its own. So you can see that I'm moving when I'm coming close to the bladder and two umbilical arteries, it's automatically capturing it. So like this, all the 20 plus 2 planes as given by ISWOG is captured. And not only that, it also tells you the quality of the image which you have captured. If the bar comes to green, then you know that you've captured a good quality image. Otherwise, you can move the probe again and capture one more time. So once you have done the whole thing, we also have, so here, for example, is the images, and you have a graphic here which tells you which are all the sections which you've already taken. So you know exactly when the scan is completed. And this is a very big boon because sometimes we miss to take out the 3-vessel trachea view, or any other view can be missed in the standard while doing an examination. And then it asks you to confirm whether this is really the image you want to accept or no. So the AI still gives you the option. It thinks, I think this is the correct image, but you can decide whether the image is correct or no. So there's still a role for the operator to do. Now, let's look at the fetal phase here. Now, here is a normal fetal phase by 3D. I'm putting the 3D region of interest, and I'm going to take a sweep. And once I take a sweep, I'm going to get an image. But this image you're getting it like this, and there are some, the placenta and other things which are there in front. Then we have now what is called as a smart scene 3D, where the moment you put the region of interest box, the system understands that you are looking at the face. I put the 3D button. It tells me that you are looking at the, I say smart scene, and says you're looking actually at the face. And once you look at the face, it adjusts itself about the way the face should appear. And once you update it, then you can go and see the face has come, but the placenta has also come here. So all you need to do is go and say, I want to see the smart face, and it will automatically remove whatever is in front and then give you the face alone. So here is the face alone which has come. So this makes the process very, very quick. Now let's move to CNS. So here is a routine ultrasound I'm performing on this side, and I'm looking at the 3 cranial planes and the transventricular, transabdominal. I'm doing the biometry. I'm doing a lot of things here to complete the egg. Whereas when I use AI, it's automatically telling me, oh, you're looking at the brain. Now let me readjust myself to looking at the brain. It'll not only take the sweep, it'll recognize all the structures and they auto measure, and it does all my measurements like cerebellum, biparietal diameter, so on and so forth. And also says the comment. So it marks all my things automatically. And then when I say I want the volume of the brain, it instantly gives me the volume. Now what's happened here, the time taken was 2 minutes 22 seconds by routine scan, and time taken is only 52 seconds by this. So a lot of time saving. The number of keystrokes will be reduced. Now let's go to the spine. So here is the spine, and when I look at the spine, I do the 3D of the spine, but it's not very satisfactory. I need to do a lot of manipulation to get that. But then when I move to the smart sign, see what happens. It now automatically gives me the 3 coronal planes of the spine, and I can just place a button at one point and tell me which is the 12th vertebra. So it gives me what is T12. So whenever I want to see, it's marking the T12 automatically and giving me the cross section there. And it helps me to actually identify the level of the conus medullaris. And this is important because when we are looking at spina bifida, it actually tells me that the conus is at L2, L3 level or below, and helps me to say that there is a tethered cord which is here. This is a very, very big advantage. Otherwise, we'll have to spend time on counting the vertebra and then identifying the point. Now, this is one of the articles which we published some time ago, where we can take the 4-chamber view of the heart, and automatically the system will identify the 4 chambers and also give you the measurements quite accurately. Now let's move on to from acquisition of images to image audit for certification. We all know that nuchal translucency certification done by Fetal Medicine Foundation, UK, but of late Fetal Medicine Foundation has stopped doing the certification and they have transferred the responsibility to India. So the Fetal Medicine Foundation India Trust has been formed, and where what we have done is we have created an artificial intelligence algorithm to ensure the moment you give the image, it will automatically say this image is passing the test or not passing the test. And that saves a lot of time. We can do it for NT images. We can do it for the 20+2 anatomical images and also the Doppler images. Now, the future is machine learning and deep learning techniques, learning from experts. So if an expert is actually using the ultrasound machine, the equipment will learn from the experts, and whatever knowledge it has captured can actually be transported to another machine, and that will be able to train other doctors who want the training on that. So this is a great possibility which is happening in the near future. Now, the future ultrasound report. Also, a machine has been developed in India, which is soon going to be shown, is that there is a black box. That is it. There is no ultrasound machine. There's only a probe, and you just need to move the probe 3 times longitudinally and 3 times transversely, and it will give you a report like this. Single live fetus at 20 weeks and 2 days. Liquor is adequate. Placenta is anterior high. Visualized portions of anatomy appear as per described norms. There's inadequate visualization of the lower limbs, and further examination is required. This is the report it will automatically generate. And then moving to not only obstetrics, but also to gynecology, you find that today AI in pelvic ultrasound has enormous value. Automatic measurement of the endometrium, the uterine volume, the ovarian volume, and also the follicular measurements which are there, all that is completely automated. And this saves a tremendous amount of time, especially automated follicular measurements. So the future is it can read even further. That is, the endometrium, it can characterize the endometrium to say probably which day of the cycle the endometrium is. So the future is that the machine will actually say, this ovary looks appropriate in size and has 12 antral follicles. You can go ahead with stimulation. She is at high risk for hyperstimulation. And the uterine myometrium appears homogeneous and symmetrical. The endometrium shows a triple line sign and corresponds to the 13th day of the cycle. These are all possibilities which are going to come. Then I'll add a little before I finish, I will add just a few things about pregnancy complications to predict. One is preeclampsia, second is gestational diabetes, preterm birth, fetal growth restriction, stillbirth, and neonatal morbidity. There are conventional linear regression models for all these, and there are machine learning pipeline also. Let's look at preeclampsia. The pathophysiology of preeclampsia, as we know, is incompletely understood. Data-driven techniques lead to improved early diagnosis, personalized risk assessment, optimized treatment and remote monitoring, and uncover molecular basis of preeclampsia. So this, when you look at the predictions, the key predictors of mean arterial pressure, prior preeclampsia, PLG of Pape has 63.6% at low bias and 27.3% high bias. Only 27.3% is externally validated. So the future is standardized predictors and prospective validation. And they found there are several models. They have found that one particular model is actually functioning quite well. And what about small for gestational age and interpretation of biometry? We know there are different growth trajectories in different populations. Accurate dating is essential, and accurate birth weight is is very useful. There is an India-specific model called Garbini GA2 to accurately determine gestational age in the second and third trimesters. It uses advanced data science and machine learning techniques trained on a large data set of Indian population data. And this is developed by the Garbini cohort in North India. And in Chennai, we've also developed this birth weight prediction using what is called as the Gompertz model. There were 744 women with singleton pregnancies, at least 3 scans, maternal characteristic, and the Gompertz formula parameterized as given. And it shows that if you look at the error, you take all the formulas, the Gompertz formula has got the lowest error among all the Hadlock formula or other formulae which are already in existence. So this is a good future. Then what about predicting preterm birth? We know that we do cervical length for preterm birth. Short cervix is less than 25 millimeters. And when you look at the parameters predicting for preterm birth apart from cervical length, it is different for different trimesters. In first trimester, second and third trimesters. And we can do logistic regression. We can also do machine learning with all these parameters put together. And what they found, the first trimester model has got a sensitivity of only about 50 to 55%, whereas the third trimester model has got a sensitivity of about 71%. And the performances are increasing because as training, this is very, very recent. So as more and more data is put in, this will become much, much better. So let me move to using machine learning to precision medicine. Now here is a patient with GDM, right? And then we know that when the person having GDM, they've got a higher risk of developing diabetes later on. So these women are supposed to follow up. So what they did was they used machine learning prediction of non-attendance to postpartum glucose screening and subsequent risk of type 2 diabetes following gestational diabetes. So women who did not attend postpartum glucose tests were younger, multiparous, obese, and continued to smoke in pregnancy, higher fasting glucose at antenatal OGTT. Machine learning algorithm actually predicted these are the people who are unlikely to come back. And 24% of them had dysglycemia at 2 years. So those who did not attend, because the machine was able to predict, the hospital called them and said, you have to come. And when they come, they found that they were able to avoid them developing diabetes later on. But those who did not attend, had a higher conversion rate of type 2 diabetes, about 2.5%. Then we have to go to decision support system. So we have now AI software to assist in the diagnosis of anomalies and associated syndromes. So what happens is, this is called as a Sonio, and they have been able to recognize 294 syndromes, 688 anomalies, with an accuracy of over 95% for the top 7 diagnoses. So you need to put in the ultrasound features, it will come up with the syndromes, possible syndromes which is there. But there are limitations. We have to understand there are data limitations, small single center data set. Second is generalizability. And that's why this adaptation becomes very difficult. Because supposing we developed an algorithm in Chennai, will this algorithm work in Jammu and Kashmir, for example? Or will it work in the United Arab Emirates or work in Indonesia? So second is interpretability. And the black box models reduce clinician trust because we don't know what's happening inside. So when it gives me information, should I trust it? Should I not trust it? And we know that AI can also hallucinate. So we have to be very careful about it. Then, of course, the outcome definitions are inconsistent, bias and ethic, clinical integration still is going to take a long time, and there are technical issues also. So I'll conclude by saying machine learning empowers clinicians, does not replace them at this point of time. And I'm underlying the word at this point of time, but it's going to be there for a long time. At least we will, in our era, it will not happen. And it shifts care from reactive to proactive. And that's very important. Better maternal and fetal outcomes and future of safe motherhood is equal to is intelligent machine learning use. We have to be extraordinarily careful in which algorithms we choose, and it has to be reliable and consistent, and so that we don't make wrong decisions based on AI. Once a wrong decision is made, we cannot blame the AI because the AI will not be held accountable in the court of law. So I thank you and invite you all to Chennai, September 24 to 27 for the 19th CUSP conference with 6 workshops and 2 days conference. And thank you for this opportunity.
Thank you so much for and yet another brilliant talk, sir. So can we have comments from our chairpersons, please? Dr. Renuka ma'am, Dr. Vinayak sir, and Dr. Rachna ma'am.
Thank you very much, sir. AI is the future. We have to stay with it. We have to learn, and machine learning is our next task. And you have always shown the torch, and you have guided us that you need to keep changing with the times. And it was a very nice lecture, sir. We will surely follow it. Thank you very much, sir.
Dr. Madhumita, you can introduce Dr. Chinmay Ratha, ma'am.
Please unmute, ma'am. Madhumita, ma'am.
Yeah. Yes. So moving on to the second session, we have a very interesting panel on borderline findings in fetal scans and how to proceed by none other than Dr. Chinmay Radha ma'am, who again needs no introduction. She's a director and a very senior consultant in fetal medicine in our country. And she's the president of Society of Fetal Medicine Telangana chapter and past chairperson of Foxy Perinatology Committee, member of Scientific Committee of IMA Telangana, and member of AICC RCOG IRC South Zone Committee.
Okay, Madhumita, we'll move on. Thank you.
Welcome, ma'am. We're honored to have you today with us.
Thank you.
And we have our eminent panelists with us today, Dr. Amit Chopade, who's the obstetrician gynecologist at Chorpade Hospital at Temburni, and sir specializes in high-risk pregnancy, and he's the secretary of AOGS currently. Next slide, please. Yeah. And we have Dr. Manisha Jagdap, who's the president of Nasik Society, and she's also the secretary of IMA Nasik. Welcome, ma'am. We have Dr. Saira Ranjan, who's a consultant and eminent fetal medicine specialist at Coimbatore, and she's also done her fetal therapy. Welcome, Saira. Next, we have Dr. Dr. Revati Chandrasekharan, who's again a fetal medicine specialist and eminent fetal and who currently practices in Trichy. We have Dr. Sangeeta Tashpuria, who's a infertility consultant at Vedansha Hospital and Test Tube Baby Center, and currently ma'am is the president of NOGS. Welcome, ma'am. Dr. Nupur Kushal Mittal, who is the director of Medicare Hospital at Thane, and ma'am is a very senior gynecologist who specializes in obstetric ultrasound, and she's currently the Secretary General of TOGS. Welcome, ma'am. Dr. Preeti Vyas, who is the Managing Committee member of MOGS and also the patron member of MOGS, MOGS Youth Cell member, Joint Treasurer of Mumbai Chapter of ISOPAR, and Secretary of Maharashtra Chapter of Osteoporosis Society of India, and Chairperson of AMOGS Endometriosis Society. Welcome, ma'am. We have Dr. Nivedita, who's again a senior consultant of fetal medicine, currently practicing at Salem, and she's a director of MediPlus Scans. Over to you, Chinmay, ma'am. Yes.
Thank you. Thank you so much, Madhumita. And after that wonderful lecture by Suresh sir, I think the stage is all set for us to move on to the next session. The only difference is that nowhere AI can help us in this topic, because the topic that we are going to now discuss is something which is an enigma even to the natural brain. Today, actually, I had a patient who is a software person, and he told me, okay, our brain is like the natural extension of AI. And I thought that was the last nail in the coffin of human intelligence, where we will start thinking that our brain is just the natural extension of AI. But we have to understand that while AI will help us in imaging, in interpretation and everything, finally facing the patient with a plan is going to be our own, challenge. And not only intelligence, there's a lot of emotional quotient that is involved here. There's a lot of, your heart and brain has to come together for handling this situation, which is called as borderline findings. So with that, I welcome all my eminent panelists here. I can see some of them. I don't see all of them, but when we call them, I'm hoping, because some of them are not named as per their thing. So let's move on. So the topic is gray zones, that is borderline significance. So what exactly is borderline significance? So the purpose of an antenatal scan is to give us idea about the structure, growth, everything, whatever we have to see. And the answer always is good when it is yes or no. The problem which happens is when it is a maybe kind of situation. So when it is a maybe kind of situation, it's called borderline and it confuses us. So let me start with a quick sentence from each of our panelists. What do you think? I mean, are you faced by this problem of borderline problems, or you're always very clear? Whenever I can see Dr. Nivedita right on top of my screen. So Dr. Nivedita, do you face borderline situations, or is it only dumb people like me who have these problems?
No, ma'am. Frequently, we used to encounter.
Dr. Saira?
Hi, ma'am. A day in and out, we've come to this borderline findings, and it's always a dilemma, especially when the patients do doctor shopping and come to us as third or fourth opinion.
So multiple doctors will get involved in it. Revati?
Yes. Madam, it is definitely a gray zone. And you being my teacher, you have guided us properly, like how to actually get into the gray zone and how to actually counsel the patient properly. Yes, indeed it is a gray zone,
But
madam.
it is a day-to-day problem for you too, isn't it? Dr. Preeti, I think you are named as Dr. Amay Purandare here. You'll have to rename yourself. But what do you think about borderline findings? Because you are on the other end, more like an obstetrician. Do you suffer with the problem with borderline findings?
Preeti ma'am, please unmute yourself.
Can you hear me now?
Yes, ma'am.
Yeah, I'm not able to change it. I don't know how
I will change it
name
for you. I will change it for you. Yeah.
Yeah. So, yeah, I think that is the norm. I think I would agree with what even Dr. Say and Dr. Revati also said, that or Nivedita said, that when people come to you with second, third opinion, I think what really helps us is when the patient has directly come to us, when the sono has already been done by a fetal medicine specialist, now life is much easier. Because a lot of
But
times
you do face borderline findings. And Manisha, madam,
all the time.
Dr.
I think the
Manisha.
most common one is, there is a stomach bubble issue, or then there is a coral plexus cyst, or then there is a issue with this thing in the heart, and then
Ecogenic focus in the heart.
focus in
We'll
the
go
heart.
into
And
the details. I'm just trying to take an overview of whether or not this point is relevant for all of you. So Manisha, madam, I can see you, Dr. Manisha Jagtap.
Definitely it is a point of issue, because day in and day out we come across with such findings, and counseling is the most important thing that we have to do with the patient, because they are really worried about
Borderline. When it is clearly yes or no, you have an answer. When it is borderline, you just have to go on talking to no end. Correct.
not
So,
giving
all
me,
the
sister.
doubts
She's
and
trying to call me.
questions that come across for them.
yeah. I would request
I'm
all
on the
others to
thing.
please mute themselves because it's causing a bit of a disturbance. Thank you. And I cannot see Dr. Manishi, Dr. Nupur Mittal, or Dr. Sangeeta Tajpuria. If you were here, or Dr. Amit for that matter. Are you here? Okay, so we'll move on with the panelists who are here. And once we have established that it is definitely something which bothers us, we know that when it is a borderline finding, we don't know clearly whether it is equivocal, whether it is going to be good or bad. It is in the gray zone. So it may be an impending problem. It may be something that will happen later on. So both us and the patients are not sure. And that's where we kind of suffer. So this is the first case, a 24-year-old primary gravida. She's attending a routine anomaly scan. The fetus is average for gestational age, and there are no obvious structural defects, but both the renal pelvis measure 5 millimeter. Okay, I'll start with Dr. Saira. 5 millimeter, is this normal or abnormal? 19-week scan. You've done everything else? Yeah.
For 19-week scan, the renal AP diameter of 5 millimeter, it comes under urinary tract dilation of A1. If rest of the renal parenchyma is normal, ureters are normal, and bladder is normal.
So is it normal or abnormal?
It is abnormal.
Revati, is this normal or abnormal? Unmute.
I would say it is a normal variant rather than being
There we have the
abnormal
controversy.
finding.
We have two high-tech fetal medicine doctors, one from Salem and one from Trichy, and in between that, one says it's normal, one says it's abnormal. We'll go to the third person because we also like shopping. Nivedita, normal, abnormal?
Ma'am, it may be a transient finding, ma'am. So we need to be
You're not answering normal or abnormal.
abnormal, ma'am.
Now, Dr. Manisha, this is your patient. You look at that kidney, it doesn't look so bad. One person is saying normal, somebody is saying transient. So how do you respond? What will you do?
Just tell that it is a little variant and need to follow up.
Okay. So that is where the problem starts because first of all, we have to check whether it has been measured correctly or not, because this happens very often that, the renal pelvis is measured in different dimensions and reported. So I would like Dr. Nivedita, one of our fetal medicine doctors, to just tell us what is the correct way of measuring the renal pelvis.
It should be measured in the axial section. The spine should be at 12 o'clock position, and the AP diameter of the renal pelvis we used to measure them.
So antero-posterior. So the picture
Antero-posterior.
where I have marked it as a tick there, that is the actual section where there is an axial section and you can see the AP diameters, and then you can make sure that this is completely okay, isn't it? However, the other picture which you see here, that is a coronal section. And if you measure that, you're not measuring the AP diameter, but actually you're measuring the long diameter, and that could be a problem sometimes. So that is why it has to be sure that you have measured it correctly. Okay. So that's the first thing. And then any other information do you need, Revati?
Yes, madam. I do want to evaluate the kidney structure properly. I want to know what are the system that has been dilated, whether it is an isolated renal pelvis dilatation or the primary secondary calyceal being dilated. I want to know whether the parenchyma is normal, whether the ureter is dilated, bladder is normal, and how is the like. I want to know all this information to conclude what classification I can put this dilatation into so that my counseling will be followed accordingly.
Okay, so all those details you need. So when you report a borderline finding, it is also important to give the associated information so that the other person understands what exactly this means and whether this is going to be a problem or whether it's going to be okay. So Dr. Saira, suppose you had to sort of explain that to the patient that now it is, because the words that we are using is urinary tract dilatation, and we are not wrong in using that word because that is how it has been defined now. Earlier we used to say mild pelviectasis. That was a very soft, easy way of saying this. But now when we say UTD A1, that means urinary tract dilatation A1, and then you have artificial intelligence available on your phones. People will immediately do a chat GPT or a cloud search there and find out that it means so many things. So how do you address this problem? How do you explain this to your patient, and how do you explain it to the obstetrician? How do you take it forward?
Usually in counseling, what we put is, ma'am, when we come across a urinary tract dilatation A1, we put it like it is seen in 1 to 2% of the fetuses prenatally, and 85% of them resolve in the antenatal follow-up itself. And if it is in the lowest category, where the ureters are normal, the renal parenchyma is normal, and bladder is normal, they have got a favorable prognosis. So it is quite, the counseling will be quite reassuring.
For a 5 mm of renal pelvis, you have very nicely reassured the patient. Now, suppose it is a dilated bladder situation. Dr. Nivedita, again, borderline, dilated bladder situation, mild dilatation, 7 to 15 mm.
Ma'am, we used to see whether it is unilateral or bilateral. Then again, extended renal sonogram, whether parenchymal appearance, echogenicity, whether it got increased or any other dysplastic changes are there. So it can be lower urinary tract obstruction also in case of dilated bladder. So we have to, in case of dilated bladder,
You'll start thinking of a lot of other things there.
structural obstructive.
Depending on which part of the urinary tract is dilated and how severe it is, you will worry about it. So up to 4 mm is considered normal renal pelvis, 5 mm is increased. So now how do we counsel the patient? So Dr. Manisha, they will tell us, the fetal medicine people will tell us how they counsel thing. What is it that you want as an obstetrician? How do you want us to handle this situation?
Yeah, as an obstetrician, I would really see that at this stage, along with the kidney parameters, what about the liquor?
वो सब बता दिया उन्होंने. They told no, वो पूरा, they gave you a huge list of things that they will look at it. वो करेंगे. But when the patient comes to you,
then patient, but initially it is just a counseling part. We have to reassure that it is very mild dilatation, and after with the follow-up scans we will come to know whether it is increasing or it is regressing. If it is regressing, then nothing to worry about, but if it is increasing, then we have to think of whether the baby will be having some other associated complication, and then explain accordingly.
So we have to give them an overview of things.
Yeah, 19 weeks will be like a gray zone, because we have to keep a follow-up, and in case if something goes wrong and more complication occurs, then we need to think of the termination also. So along with that, we have to think of.
Okay, now just 1 minute. I'll stop you for 1 minute. 1 minute. Because we had we started with see, the whole concept is a borderline finding.
Yeah.
Now, borderline finding, are we going to discuss termination at this stage with the patient?
No, we have to reassure. Reassurance.
So this is for you. This is for you to understand. So here I would like to drive a concept of information on a need to know basis. And this is what I have started telling the patients also. It's very good for us to give you all the information. There is no doubt about it. But at the same time, it is good if it is on a need to know basis, because you can't handle all the information that you take. So it is true that this can increase. It is true that there can be other problems, but at the same time, it is very, very important that you understand that most of these cases are transient and they do not need to be worried about, because they may be because of the maternal relaxant hormones. And only if it increases, and how will we know if it increases? We will see it after 2 to 3 weeks, and then we'll see. Only if it is very prominent and it goes to severe hydrourethronephrosis, then only you will need postnatal intervention. So Dr. Revati, would you follow this only, or you have learned so much in fetal medicine that you want to give all the information to the patient at the same go? By chance she goes to another doctor and she says more things, the patient might think, I don't know all these things.
No, madam. I would want to keep the patient to myself by giving the enough information to them, which will not, create unnecessary, hurricane in the patient's mind. I will only give this much of information, telling that this could be a transient or physiological finding, where it could be due to an immature PUJ junction or the smooth muscle or the maternal hormones, and it has a tendency that 85% of the time it can resolve. So I will just need a follow-up after 4 weeks to know whether it is going to progress or regress or going to stay the stable. So that much information will be enough from my side, madam.
So the dilemmas in our counseling are variable onset, variable presentation, multiple etiology, and variable prognosis. So in some cases, it might remain just the same. In some cases, you can see that it may just, increase later on, and you may see a much dilated urinary tract system there. So the whole concept is that it could go either way. Your counseling has to be just right. It should not be very scary, because in most cases it gets better, but not too reassuring, because it's not like every case will be fine. In some cases it will increase and there may be a need for intervention. So how do we counsel patients, Dr. Preeti, without scaring them? If we don't give them enough information, we are holding back information.
All conversations.
Yeah, I think you don't want to scare them. You don't want that apprehension to be there so bad that, they'll end up taking multiple opinions and then finally end up terminating the pregnancy.
So what is your secret? How do you counsel them that they don't get scared?
So I think what I tell them is, first thing is, see, if it is a 19-20 week sonography where it is just a 5 mm or a 6 mm, the first thing you tell them is just wait, don't panic. Okay, if it was something really bad, really significant, by now it would have already been beyond 20 mm. Okay, the fact that it is only 5-7 millimeters, for all you know, it is a transient obstruction. Maybe it is just a valve or something, and then it can definitely be corrected post delivery.
So when
and
it
we
is
don't
mild,
see any
let
other
us take it
abnormality.
easy. Yeah, because unless it progresses, it's not a problem, and we still have time. So we will see it as the pregnancy progresses. Now, another story about renal pelviectasis is it is also a soft marker for Down syndrome. So Dr. Saira, Dr. Revati, Dr. Nivedita, quickly tell me, once you see a renal pelviectasis, are you going to again talk about Down syndrome to the patient?
No. No,
Why?
madam. I will talk about the Down syndrome to the patient. Provided I do a good scan, I hunt for other markers and I don't find any other marker, and this is isolated, and the patient has got a good screening test with a good sensitivity telling that the patient is low risk for chromosomal aneuploidy, I'll leave the patient alone, telling that the kidneys alone need follow-up. Or else if the patient had not had any screening and the patient is past 22 weeks, I may suggest a good screening test like NAPT. Or if the patient is less than 22 weeks, maybe I will consider both quadruple and NAPT to the patient.
Perfect. So what we'll do is we'll look for all other markers. Yes, it is a marker for Down syndrome. We should not forget it. But if she's not had any screening in the past, then it becomes very significant right now, because we don't have any baseline to look for. But if she's had a good screening, then you need not change, because the power of just pelviectasis to change the risk is only 1.08 times. And that is not very significantly different. So that's okay, because that also is a Pandora's box that opens. So Dr. Saira, is there a difference if it is a mild pelviectasis or a very significant hydronephrosis regarding the risk for Down syndrome?
Bilateral mild pelviectasis is only a marker for Down syndrome, ma'am. And if she has got a good FTS, I will not even talk about the and it is isolated, we need not open the Pandora's box of trisomy 21 to the patient and unnecessarily panic her, I think.
So only if it is mild pelvic ectasis, we do worry about Down syndrome because Down syndrome is associated with hypotonia and that leads to this mild pelvic ectasis. But at the same time, if she's had a very good screening, we need not bother. But if it is a major hydroureteronephrosis, you're more worried about the structural aspect of the thing, and you then have to take care of that. So, Dr. Nivedita, you can just summarize it for us. Mild pelvic ectasis in fetal kidneys, borderline finding, how to take care of it.
Yes, ma'am. If we encounter mild pelvic ectasis, so we have to examine the fetus thoroughly, have to see for the screening whether she have undergone any screening priorly. So if it's a normal anatomy fetus without any markers, isolated mild pelvic ectasis with the prior good screening, which falls under low risk, we can counsel them. Like most of the time, it could be a transient finding. We can follow her up around 32 weeks in third trimester. Most of the time it will get settled. Only a small percentage of babies used to evolve, so the fetus needs to be followed up. So like that we
And how
use
frequently do you want to follow up? When you've seen it at 19 weeks, mild pelvic ectasis, when do you want to call her again?
Ma'am, around after 6 weeks we can call her, ma'am.
Yeah, because very frequently you're anyway not going to do anything. So you will see her after 4 to 6 weeks and see for the progression.
Yes.
Okay, so postnatally, who's going to do the surgery? It has to be a pediatric surgeon, and therefore, towards the end, we have to make sure that they meet a pediatric surgeon if it is actually increasing to that extent. So by the time, it will not be borderline at all. So this is the question I was asking Dr. Manisha and Dr. Preeti. How do we counsel patients without scaring them? Because obstetricians often get very bugged after the report comes from fetal medicine कि क्या बता दिया तुमने, अब patient मेरा सर खा रहा है. So what is your pearls of wisdom in how to counsel patients without
Assurance is the important thing. That patient should feel comfortable. That if we wait and do the follow-up after 4 weeks or 6 weeks, then it's going to be regressed. And in case if there is something, then accordingly, whatever the findings come at that moment, then we will discuss again. Till that time,
is there a book that we can read about counseling? Is there a short course we can do on counseling?
Actually, Chinmay, I've done an MSc in psychological counseling and therapy. It was a 2-year course. And I did it purely.
It's a 2-year course. Now, all doctors cannot do a 2-year course. So how do we get to the bottom of how can we become good counseling people?
So there are these short courses also available. I've even, as a part of my studies, when I was doing the 2-year course, I even signed up for another 3-4 courses where there was a 6 weeks course. There was another on the
one option is to do
model
courses.
of counseling.
You are very thorough, Dr. Preeti. You will do courses. What about the rest of you? Will you do courses, or what do you think? What will make you a better counselor?
I think it is just a matter of being patient, a matter of being empathetic with the patients. I think empathy is the key behind it all. You be empathetic, we give a listening ear to them all. And I think that is what most of the time the patients want.
I just place me in the position of the patient, madam. That's what I will do all the time. Whether it is a soft marker or a major structural anomaly, I would want the patient to be counseled how I want to be counseled. So that's how it's simple.
You will develop a connection with the patient, and you will tell whatever is true. You will not tell whatever is not true. But at the same time, you will try not, not actually disturbing the patient's tranquility. And it only comes with practice. Okay, that was the easy one when we had mild pelvic ectasis. Now, suppose we have a situation where we have a 34-year-old G2P1L1. The occipital horns of the lateral ventricle are 8.1 and 8.2. Let it be anything, 8.3, 8.5, anything less than 10, but somewhere there. Already Dr. Nivedita is holding her head. Yeah, you have to write a report. Okay, you have to write a report for her. So how will you write this report?
Prominent lateral ventricle.
Prominent lateral ventricle. Will you just leave it at that? Are you happy? If you write prominent lateral ventricle and leave it at that, you're textually correct. It's not wrong. But can we just leave it at that? What about the other fetal medicine guys here? Dr. Saira?
Once we see bilateral lateral ventricles of 8-ish or 9-ish, ma'am, first I will just go into the full-blown CNS examination, and to write in the report, I will write like bilateral lateral
What is
ventricles.
your indication to do a full-blown CNS examination? The ventricles are still normal. Is that an
Ventricles,
indication for neurosonography?
if it is towards a 9-ish, ma'am, I would prefer to go and do a neurosonography, because I have to write down in black and white, and I have to call her back in 2 weeks' time to assess the progression or regression of the ventricles. So before I label it as normal or abnormal and ask for a review, it is better always to do a complete neurosonography and then write down in the report, I feel.
I agree with you, but I am biased because I am myself in fetal medicine. I'll ask an obstetrician. Manisha madam, if somebody reports to you as 8 mm, and 8 mm is technically normal, they just write prominent ventricles. Will you send them again for a neurosonogram to a fetal medicine person, or how will you approach it?
I can just inform that at present it is little more. I mean, only a mild megaly, but then
It's
we
not
have
megaly. Up to 10, we are
up
considering it
yeah,
as normal.
it's just a little dilated
Prominence.
and prominent, and we need to keep a follow up and not to worry at this moment.
Is it normal or not normal? Why are you saying not to worry? If you don't have to worry,
If
then
I
why are you
can
calling her back
intervene,
again?
if I can intervene, I think I would tell them very clearly that this is normal. They've just mentioned it to be prominent. It is still absolutely within range. Just a routine sonography after 3 to 4 weeks would be more than sufficient, and you don't need to panic.
But after 3 to 4 weeks, if it increases, so ventriculomegaly, how do you approach ventriculomegaly, Revati?
Concerning this case, this is only a case of prominent lateral ventricle, madam. That is still a normal variant to me. I don't consider it as abnormal. And I will keep the patient in the loop. I will ask the patient to come after 2 weeks to look for progression, regression, or stability of the ventricles. And when it comes to ventriculomegaly, the definition starts only when the ventricles are dilated at the level of the atrium to be more than 10 millimeter, madam. So that is considered as ventriculomegaly. If you would ask me how I will manage these cases, when it is ventriculomegaly, when it is more than 10 millimeter, I definitely need a neurosonogram to understand how the brain is completely structured. I want to look at the CSP, CC, and everything I want to see, and what is the cause for the ventricles to be dilated that way. If there are no structural
Understood. Once you have got ventriculomegaly, this comes in the abnormal zone, isn't it? Once it is ventriculomegaly, it comes in the abnormal zone, and we all will go ahead and do whatever necessary at that point. The problem is when it is like 8, 8.5 and this thing. And as fetal medicine doctors, we also understand that sometimes we are suspicious. When somebody has written 8, is it only 8, or why has the person mentioned prominent ventricles? So it sometimes happens that it might have been written 8, but when you actually measure it, it will be a little more than that. So are you happy to counsel a patient based on a scan done by someone else where they have written borderline prominence, or would you want to scan the patient yourself, or you would accept it if the scan has been done by Saira or Nivedita? I'm asking one of you, Saira, Nivedita, or Revati.
Yes, ma'am. We should repeat it again, and we should measure it properly. The measurement by another person and believing them and counseling is not a proper thing.
It's tricky. It is tricky sometimes. So this is a message to all the obstetricians that please don't mind when we say that we need to scan this baby again, because if you remember, Saira said that even if she sees something like 8 to 9 mm, she will go ahead and do a complete neurosonogram. Now, if you go by the indications of neurosonography, just prominent ventricles is nowhere given as an indication for neurosonography. But this is the difference in approaching fetal scans as a fetal medicine trained doctor and just as somebody who is doing imaging, because then you think laterally. You think that, okay, when I'm going to report prominent ventricles, I should be sure that there is nothing in the brain right now which I'm missing, which can later on come up to be a problem. For example, if there is a corpus callosum agenesis, or there is some major issue which is there hiding inside the brain which can't be seen by the normal planes, then we will go ahead and look for it. So there will be a borderline finding, but the way a fetal medicine doctor doctor will approach it is that person will go ahead and look for further details, and the report will be a little more extensive and a little more developed as compared to a report which just says prominent lateral ventricles advised quadruple marker. That is how we get many reports. So I'm just trying to put it to the obstetricians how a borderline report can be done properly. But there are pitfalls in the way the ventricles are measured, and that is what Revati and Nivedita was telling, that we need to see that it has to be done properly. Now the issue is in case it is slightly more than normal, or then you don't know what will be the outcome. So how do we counsel patients with mild ventriculomegaly? Dr. Saira, I'll put this to you.
Isolated mild ventriculomegaly, when a patient comes to us, what we usually counsel them is there is 7 to 10% chance of abnormal CNS finding that can evolve as a gestation progress or postnatally, and it is associated with approximately 5 to 7% chance of chromosomal abnormality and monogenic disorders. So I would ask her to come back after 2 weeks, because 16% of the time it can progress. And if it is stable and the battery of tests, what we are going to order, that is a basic test of chromosomal microarray with QF-PCR and torch PCR. If that is coming as negative and the ventricles are stable, then it is probably on the reassuring range if I see her after 2 weeks.
So now you saw after 2 weeks, and from 8.8, it just became 10.2. So when she comes back at 20 weeks, it is 10.2. 10.2 is still, very, very mild.
Borderline.
Isn't it? This way on
Yes.
the borderline. And now suddenly you want a lot of investigations. So what are the investigations that you want now?
I will, since she's around 20 weeks, I'll order for a QF-PCR with chromosomal microarray and torch PCR. And I will tell her we will keep the DNA as stored. As of now, only the ventricles are a little bit on the higher side, and I'm not seeing any other abnormality to link with a monogenic disorder. And if I go for a VES, the yield will be very low, like 1 to 2%. So I don't want to go for a full-blown investigation. I will limit myself to CMA, torch PCR and QF PCR.
So Manisha madam, अभी इन्होंने Pandora's box open कर दिया. The ventricle is only 10.2. She feels the rest of the brain is normal, but she's given a whole list of tests to be done. And you had got the NIPT done for this patient in first trimester, who normal hai. How do you feel now? The ventricle is 10.2.
Yeah, we have to still tell the patient that though it is little increased, but still we have to keep the follow up, and there are few chances of maybe progressing of the things, and the results
So, madam, we got NIPT done. You told us NIPT is very good. We spent such a lot of money and we got NIPT. NIPT is normal. अभी क्या करने का है? Should we do all these tests? वो कह रही है amniocentesis करने के लिए.
Then I will leave it to the patients, because the patient will, when it is a primary or conceived after treatment, then they are like, nahi, humko chahiye, and we want to continue with the pregnancy, and so they will go ahead with all the investigations. If it is
हाँ जी बोलिए.
If it is a second pregnancy, then patient prefer ki madam, instead of going for so much of investigation and spending so much of money, we will terminate the pregnancy and take a next chance.
I am not sure we can take an audience poll directly here, but I would request whoever audience, if they are listening to me, can you just tell me you agree, not agree that 10.2 can we mute somebody? I don't know where this noise is coming from. Yeah. So, suppose the patient wants to terminate because it's 10.2. Is it okay to terminate the pregnancy? Can we have a few answers from the audience as well? What madam is saying, I completely resonate with her, because she is not faking it. She's saying exactly what happens in the clinic. And this is something which all of us go through again and again, and none of us can say that we have not faced this situation. Even I can say that I know patients who have gone ahead and terminated, despite whatever we have told them, because that's how patients think. And the reason they can't put 2 and 2 together is because for them, brain abnormality is equal to mental retardation, is equal to whatever they saw in their neighbor's child somewhere, and they just can't get over it. Now, whenever a patient
not ready to accept the things, that to wait and watch or going ahead with the things.
So, Dr. Preeti, you've done this extensive course in psychological counseling. Now, you tell me, if the patient goes ahead and terminates because of these situations, is it a problem of her psychology or is it a problem with our management?
I think it's our management. I'm at the smallest level. And 90% of the patients nowadays come back with a chat GPT or a Gemini answer, where the Gemini is also going to make them panic. So I think it is for us to counsel them. If required, we can always do a repeat sonography at another center, because finally the difference between a 9.9 and a 10.2 millimeter is just a this thing of 0.3. So I think it'll be nice if we make them do a sonography, a repeat one at another center, to be sure that yes, the findings are really relating to that. Again, I think what I would also say is that maybe we can do a torch investigation, but whether there is any other abnormality that we seen in a structural abnormality at all is also something that we need to keep in mind. So if there is nothing else seen at all, then we should take a second opinion with a sonography, and not after a delay of 3-4 weeks, maybe within the same 3-4 days itself. And if that also doesn't pick up any other abnormality, then I would still want to counsel them. A 10 mm and a 10.2 mm is just a difference of 0.2. There can be a difference in the measurements too.
Okay, we would like to have that, but suppose it is 10.2. The problem with fetal medicine people is we cannot overlook the fact that many of them may have genetic conditions, and so the advice for these tests will have to be given. Will patients accept it? Will they?
We can tell them to go
No,
ahead
we have
and
to
do
tell
a
them because
study further of amnio and everything that you already mentioned.
Correct.
And let those investigation reports come, but don't jump and immediately terminate the pregnancy unless, of course, the patient just can't afford to do those investigations at all.
No, I don't think it is about the obstetrician wanting to terminate the pregnancy. It is that when we tell them so many things, the patients get overwhelmed, and they get overwhelmed thinking that, oh, so many things can go wrong. When you're telling them that I'm going to do a test for chromosomes, I'm going to do a test for genes, I'm going to do a test for infections, suddenly in their mind, they feel all these problems are there with the baby, and then they get a little overwhelmed. So when it is a gross abnormality, many of us are justifying all these investigations. But when it is a 10.2, 10.3, like you all reacted, maybe it's a difference in measurement, maybe it is something, we all are trying to rationalize that it may be normal. So that is why in the borderline findings, everybody finds it difficult to accept the fact that this can get worse, and I better be prepared for that. So the way we approach it in fetal medicine is we prefer to do off the test more for reassurance. Doing the test saves more babies, because then you know that the microarray is normal, there is no major mutation abnormality, there is no infection. So tomorrow if 10.5 becomes 11 also, I am more reassured, because I know that everything else is normal. This also may be a reaction of that, maternal relaxant hormones or a normal transient finding. So doing the tests is not wrong. Counseling. So ultimately it turns out to be counseling only. I mean, unless you learn how to counsel patients without scaring them, you will be in trouble. And this is one of the examples which I might have taken, because again, with a very mild ventriculomegaly, we did get a result which was trisomy 21. So that also happens. And therefore, checking is very important. So the doctor's dilemma here, the doctor's dilemma here is that, isolated issues have low likelihood ratio, low propensity for major problems. But you remember that low is not no. So you can't tell them that just because it's 10.2, it will be okay. It might not be okay, but it has to be checked. So again, talking. Instead of one, you have to talk about 4-5 sentences and things. So anything you want to add here, anyone?
I think one more thing I'd like to add is that whatever we have advised them, about the extra investigation and everything, we must document it. Most important.
Absolutely. Yeah. Documentation is important because that is for our own safety and posterity, where you can go back and say that, look, I had told you to do these tests. But the more challenging part is giving the right information and getting the right outcome out of it. So if after your counseling the patient is getting more scared or going and doing a termination without somewhere we have failed. Like you said, somewhere there's a problem in our management. But again, patients will do whatever they want because their perspectives are very different. So this is a little cartoon which I like always seeing, that it's the same thing which you see on two different angles. You have a different interpretation of that situation. So what might be a very straightforward quadrant thing for the doctor might be a loop for the patient. So when we counsel patients, we counsel with our brains and we think everything is like a jigsaw puzzle and it'll fall in place for the patient, whereas the patient is listening from the heart and she's just not paying attention to half of what you are saying, and she is just very emotional because something is wrong with the baby that she's carrying in her body, and therefore she may not actually be taking it. So it's a multi-step process and we have to understand this. Now you saw her at 8.6 mm and things were better. So you told her it's okay, it's all reassure, reassure, reassure. I remember the obstetrician said that. Manisha madam, you said reassure, reassure, reassure. Now 26 weeks, it was 10.2 mm. And now at 34 weeks, it is 16 mm. What will you do now? How will we respond? How have the risks changed? What do we do? So you will refer to fetal medicine first of all. So now, Saira, the patients come back to you.
So, ma'am, have we done all the investigations, ma'am, and everything has come back as negative, I hope, and we have only whole exome sequencing left behind. So now I'll go ahead and start searching for any other additional finding which I can fetch and put it as syndromic. And so I will do again a targeted fetal neuro with a
You did a
detailed
neuro
search.
that time. You did all the tests that time. Ab fir kya milega?
Still, again, it
Why?
should be it should be a never-ending process, ma'am. We need to look at
Evolving
the
anomalies
sulcation,
also will happen,
gyration,
ma'am.
all those things we need to look, and I need to see whether any hemorrhage has happened and how is the pericerebral spaces. So the targeted neurosonography will be a repeated process whenever I'm going to see this patient and the ventricles are increasing trend.
But why? Were you not paying attention in the last scan?
Many things will evolve, ma'am. So in the first counseling itself, I have put it across like 7 to 10% of the findings are going to evolve during the period of gestation or postnatally, even if it is a mild lateral ventriculomegaly.
Because for CNS, the development is a continuous process. And therefore, you cannot stop at that point. And that is the reason sometimes in the scan, we write all congenital anomalies cannot be picked up by scans, because some of the things will be presented later on. And even after birth, you might get a few of them. So just like low risk was not no, high is not yes. So even now things might be okay. Because there's always a percentage that can be okay. But the important question which she asked was, have we done all the tests in the past? So that is where the obstetricians also need to understand the importance of doing the test at a time when it is still borderline. Because if you do the test, you are much more secure when something like this comes up later. Tomorrow, she should not say that this was not tested for us. We have so many scary stories in fetal medicine to share. We don't want to do that here because we'll stick to our borderline findings. But the message that we want to give, I think my co-panelists will agree with me that in the borderline phase, do off the tests so that we are mentally free. If at all it progresses. If it does not progress, none of us need preparation for good news. But if it becomes bad news later on, whatever we could have done at this stage, we have done that. Because if the outcome is bad, the patient is never going to say that, oh, madam, theek hai. Oh, बोलेगा, मैंने तो आपको बोला था. I had asked you. If you had told me, I would have done the test. You would have told little strongly, I would have done the test. So you have to have this counseling proactively that, I am asking you to do the test. This is as strongly as I can tell you. Please do it. So now, of course, if it is 16 mm, Dr. Preeti, 16 mm at 34 weeks, how would you feel?
This is going to be the tricky one because now we will have to face the music with the patient. So I think obviously it will go to the fetal medicine person. We'll have to counsel the patient that even post-delivery, the child will require some amount of evaluation. Maybe the baby will require an ultrasound as well as an MRI post-delivery, whether it is a ventriculomegaly, which is only of the lateral ventricles, whether the third, fourth ventricles are also involved. I mean, all that entire thing, we'll have to evaluate the child in detail. And of course, we'll have to keep counseling the patient that, yes, we do understand that there was something which was borderline in the beginning and it has now evolved, which means that probably there is some kind of an obstruction somewhere. And that's the reason why it has landed up progressing, or then whether there is any other abnormality that we can see now and it has evolved, because this will require probably some amount of management and surgical correction even later on
Correct.
after delivery.
And if it is really bad or proven to be bad, maybe you can do an MRI and see that if there is an evolving cortical abnormality or something like that, then you probably can go for what is called as a late termination with the help of the legal methods that we have now. Now, isolated markers will I mean, we've had discussion on two issues, one which generally turns out to be normal and one which may become something scary, but you start with borderline and then move either way. So in renal, we were not so worried because we knew many of it will resolve, but in brain, we have to be careful. And therefore, it's not wrong to go ahead and do a series of tests while you see it is prominent and borderline, because if it increases, then your reassurance will only be provided by the tests that you have done, because many things you can't see. So suppose there's some isolated marker like a short femur or a short humerus. Rest of the baby is absolutely fine. Just about, third centile, fourth centile, fifth centile humerus. Dr. Nivedita, how do you feel reporting this?
First of all, I will see for the mother's height and father's height, whether it is familial. Then I will check with the dates, whether the dates are corresponding. And short femur and short femorums, then we have to rule out other components, head circumference and abdominal circumference, whether it falls under FGR category. Then after ruling out only isolated short femur humerus means will do the skeletal survey. Other long bones also, and femur foot length ratio and thorax, I will assess whether it comes under the category of skeletal dysplasia, whether it is lethal or non-lethal. Then obviously I will see for the soft markers, associated soft markers also, though it's a low likelihood ratio. Then in history, I will notice, I will see for whether she have undergone any screening priorly, low PAP-A.
So you'll do a lot of extensive work, and I'm very happy that all of you are highlighting the importance of looking at the fetus from a fetal medicine perspective. And I hope all our obstetricians now are very, clued into the fact that it is a good idea to have their fetuses evaluated by people who are trained in fetal medicine, because these are people who have spent time, learning more about the fetus and understanding more about fetal physiology and pathology. So the reports, as you can see, even for borderline findings, they are going ahead and checking many other things and giving you a report which is going to be so much more meaningful than just writing short femur. So this report will come as a composite report, which will say that, okay, femur is short, but definitely all other bones are proportional. They're long, their echogenicity is normal. So you're not thinking of skeletal dysplasia as the first thing, because they've already given you a lot of clues that it's unlikely to be that. She even checked the mother's height because it could be a familial feature. So then you take it forward from there and suggest serial growth. In India, particularly, many people are of a low average height. And therefore, if there is also an added FGR, you may get bones which are on the lower centiles. So we should not panic with it as long as all other features are fine. And of course, you look for the screening history and the thoracic diameter, everything else, and serial monitoring of linear growth. So again, another borderline finding is a flat nasal bridge. The nasal bone is normal, but there is a flat nasal bridge. Now, Dr. Saira, how would you report this? What would you say to the patient?
Flat nasal bridge, I'll first of all see how the profile of the patient and her husband is, and
Familial.
then I'll ask.
Familial is a possibility, yes.
Familial. And then I'll ask her whether she was admitted for hyperemesis. And then I'll ask whether she is having any small joint pains, or she is any rheumatoid patient, or she is a ANA positive. If rest of everything is normal, then as a first step, then I'll go again and check about the epiphysis, whether there is any epiphyseal stippling, or if there is any premature ossification of the coccyx, where I need to label this as part of chondrodysplasia punctata. If rest everything is not there and only flat face is there, I'll check whether the first trimester screening is done. If she has got a good first trimester, reliable first trimester screening done and it is a low risk, first I would like to go order a ANA to see whether she's ANA
She has
positive
any
or not.
immunological condition. So a very
Yes.
simple borderline finding like a flat nasal bridge opens again a whole window of multiple things. So what one message I think which you are giving all of you in borderline findings is rule out whatever it is possible to rule out. And if you've ruled out those problems, then the chances that things will be okay on your follow-up will be fine. If there are things which you cannot effectively rule out, suggest those tests, even if it is invasive, even if it is borderline and the possibility is sinister, for example, in mild ventriculomegaly, then we can proactively go ahead and test. For a mild pelviectasis or other things, you may be a little more relaxed about the testing. Am I right in what I've understood from your inputs, or you want to add something here?
Yes, madam. Totally agree with you.
So this is, I think, the last case that we will do. So this is again about dilated bowel loops. That is again another, borderline thing that keeps wondering. You see that a bowel loop is prominent. Now I put two pictures there. In one, it definitely looks like a very huge segment of the lower one looks like a hugely dilated thing. So probably that will come in the category of abnormal. But if you look at the upper one, it is not very unusual to see this in your scans. So I will go to Dr. Revati. How do you approach prominent bowel loops in your, do you look at them? Do you mention them?
Yes, we do look at them and we do mention them in the report with good caution, madam. So first of all, when I see a prominent bowel loop, which is not much dilated like how it is given in the second picture, I will go on to look at the extensive GI tract. Matlab, the upper abdomen and the lower abdomen will be carefully evaluated. And I will look at which part of the bowel is looking prominent and how the wall is it echogenic, whether the content is echogenic or just a fluid filled one. And I will go back and look at the PAMC, the perianal muscle complex, also to look for low analgesia and everything. And I will, in this condition, I will definitely go and if it is a large bowel prominence, then I would like to go and see whether the good screening test has been done or not, and how is the fluid, whether any history of first trimester bleeding was there or not. Everything I'll be checking, and I'll be asking the good history of whether the mother has got any history of fever or any perinatal, should I suspect any perinatal infection. Everything I'll be asking from the patient to come to a composite conclusion whether this patient needs further detailed evaluation or how frequent I should be evaluating and what further testing I should be offering the patient.
Yeah. So the problem, the thing is, when we look at this bowel dilatation, we will look at the lumen of that bowel and which segment of the bowel which we are expecting. So if it is a small bowel, it will go through and through the abdomen, so that you can say it is a small bowel. If it's a large bowel, it remains more in the periphery, and you can see certain features there. So again, like all other findings, this may be a normal thing. It may be, the thing about borderline findings is they may be normal, and if they are normal, then how much should we intervene, how much should we tell the patient? That is your fear. So in bowels, like you very rightly said, you look at every other possibility that you can rule out at that point and keep it on follow up. If you are seeing an gross abnormality, for example, the second picture that you see here, there's a hugely dilated large bowel segment, and it may be an obstruction, it may be something which will require surgery postnatally, then what will be your approach?
If it is going to be like the second picture where it is hugely dilated, this is something called as megacolon, madam. So I'm suspecting more of a genetic condition and an obstructive pathology. I'm struggling with both of them. So I would want to rule out at least one of them by doing an invasive testing and rule out whether genetic or a congenital, genetic or a chromosomal abnormality is there. Once that is ruled out, I will have to explain the patient, telling that I am thinking more of an obstructive pathology, which will be needing a surgical correction post birth after evaluating the baby. So that will be my counseling to the patient.
So while it can be borderline now, it can progress into something like that. So you have to give them the whole picture that, it might be a whole spectrum of presentations as it is. But the important thing is there is correction available. Prognosis for these will be good after correction. The only thing we need to rule out is an inherent genetic disorder. For example, in the small bowel loops that you see there, Saira, what will be the first thing that comes to your mind when you see small bowel loops like that?
Multiple small bowel loops, equal diameter with peristalsis. First thing will be congenital chloride diarrhea.
Chloride diarrhea. So these are things which will only come to your mind when you have had a proper sort of exposure to fetal medicine cases. And therefore, that is where I would also like the message to go to the obstetricians that if your reports are completely normal coming by any imaging center, don't bother. But if they have anything that they report, please send to somebody who understands fetal medicine, because that picture is not just about, bowels. It is about a genetic condition which will present as congenital chloride diarrhea later on and will have an extremely poor prognosis for the baby. So whenever there is small bowel obstruction, you need to look at, the conditions properly, and then tell them that postnatal therapy is available, but at the same time, the gray zones exist and you need to rule out whatever can be ruled out in terms of genetic conditions. So I think we've had a pretty long discussion here, and the audience also will be tired. It's about 9:42 p.m. right now. As fetal medicine doctors, I think we can go on forever discussing these issues, but we need to close the discussion now. And I want all of you to give some, important messages to our audience. So our obstetricians, Dr. Manisha, Dr. Preeti, and our
Yeah. I think the simple message would be careful, but at the same time, be empathetic. Make sure your fetal medicine specialist is your friend who is there to always guide you and help you out, and document everything.
Thank you. Dr. Manisha?
Yeah, the single isolated gray zone findings have to be verified again, and follow-up has to be there, and counseling of the patient is the most important thing.
Very important. Very, very important. In fact, that is the only thing. When people ask what is the risk of miscarriage on different, antenatal procedures, I feel the highest risk of miscarriage is with counseling. Because if that is not correct, the patient will never land up in amniocentesis. The risk of miscarriage on amniocentesis is actually less than the risk of miscarriage with bad counseling. So very many times patients don't even come. We have had patients who have terminated on double marker test because the doctor said this test is being done to check mental retardation, and if it is abnormal, she thinks the baby is mentally retarded. So very, very right.
Come across the patients that with having so many anomalies, but still she wanted to continue with the pregnancy. And I have seen the patients with very small, in spite of doing all the counseling, they are so feared कि नहीं मेरे baby को कुछ, if there is mental retardation, I don't want to carry this, and they ask for the termination. So all variety of patients are there, and it's very difficult to individualize all the things in one same aspect.
So that's why our approach has to be uniform to all the patients, and we should cover as much as needs to be covered. So Dr. Revati, what about borderline findings and your take-home message?
So I find borderline finding is rarely a diagnosis, madam. It is only an invitation to look further deeper. I always ask these 5 questions when I see a borderline finding. Is it a real finding? Is it truly isolated? Could it represent an underlying condition? Will it evolve in the future? And does it mean any prognostication? Should it need any management post birth? These are the things that I go across whenever I see a borderline finding. So our role is not only to merely identify a marker, but to distinguish a normal variant from the first sign of a significant pathology. So identify whether it is just a marker or it is the first sign of the future significant pathology, so that we can counsel the patient properly and get a good outcome and save many fetuses.
Excellent. So thank you, Dr. Revati. Dr. Saira?
As my teacher always tells, it is, as a fetal medicine specialist, I think we should not seek and destroy the fetus. Our aim should be to seek and then
preserve
the fetus. So I would
Excellent.
stick on to his words.
Great. Dr. Nivedita?
I used to observe whoever is doing the first counseling, whatever that person says, it used to get imprint in that couple. So if we do the second counseling also, they won't accept. So
Very true, very true. I mean, these insights are coming from people who are seeing patients in the clinics daily, and they are very realistic. You will not get these insights in textbooks, and that is why these kind of discussions are important. Because what Nivedita just said is a very important pain point for all of us in fetal medicine. You know, once somebody it's like spilt milk. You can't change that, whatever you do. So that's very important. And therefore, one has to understand what to say. And if you do not know the right thing to say, tell them that I do not know the right thing and I'm going to wait and give you the information later on, rather than saying something offhand and getting into trouble. So, and that's why some cross information is also important. You know, you need to sometimes when there's an EIF, they go to the cardiologist. When there is a echogenic bowel, they go to some surgeon, and then it all becomes a wish-wash if they don't know what's the right thing to say. So that's very, very important. There was one question in the question and answer session by Dr. Tara K, that when the limit of TOP is 22 to 24 weeks, is there any point of postponing the decision? It's a valid question the patient could ask. So would anybody want to answer this? Dr. Manisha? Dr. Preeti?
Hello?
Yeah, the limit of TOP she has mentioned. So should we...
Keep me in your prayers, and when I meet you, I'll tell you. We can terminate if there is a gross anomalies, but beyond that, we need to go to the board and ask for the termination. And so, taking such decisions is really important. Though fetal medicine people say that wait and watch, we'll see after 6 weeks and 4 weeks, but then passing those 4 weeks is so difficult for the patient and the gynecologist, because patient again come within 2 days and with some other new relatives. Ki, madam, this is the report. Now what to do? Now what to do? She's not able to sleep. So we really have to counsel the patient and take the decisions before 24 weeks. And
So we actually need to take a decision a little earlier, because between 20 and 24
counsel
weeks.
them and assure for the continuation.
Yeah, so the point is
Yeah,
we will
but
always finish off the counseling with a complete summarization of what we have seen and how things can progress, and how it is important that we need not, stop there. We need to do more tests, and we need to be prepared for the possibility of a progression. In the anticipation of progression, terminating a pregnancy is not any more scientific. When we had these strict cutoffs for the MTP, at that point we had no other option. So maybe it was justifiable at that time that I have no other option to do if we cross a such and such gestation. Today, thankfully, India is one of the most progressive countries in terms of the reproductive choices, and we have a permission for late termination. There is a legal way that the government has opened for us. So I think we need not jump into that. How to balance the odds and tell the patient that this dilemma is something which, so that counseling session sometimes may have to extend for 1 day also. So what happens, and obstetricians may not have the time, but fetal medicine people better find that time, because otherwise what are you doing? If you are not able to counsel your patients properly, then you're not doing fetal medicine. So you have to talk to the patient and tell them, look, this is what I'm telling you, and if you are not understanding this, this is the information, go read about it, come back tomorrow and I'll get back to you. Because sometimes they're not able to process that whole information in one go. And when it is borderline, it is borderline. So it is clearly good to tell the patient that, look, this is borderline. It's neither normal nor abnormal. So we had one word in obstetrics called masterly inactivity. So that is not the same as being lazy or, being stuporose. You are not actually not doing anything, but you are there and watchful expectancy, masterly inactivity. So now in borderline findings, it has to be that kind of a, a guarded proactivism, what I would say, where you will do what is necessary, you will not do what is not necessary, and finally give a rational outcome to the patient, because your job is to balance the odds and do no harm. So if you terminate a pregnancy which was otherwise normal, that is harm. And if you continue the pregnancy without working it up and later on landing up in big time trouble, then that is also harm. So that balancing act is what we have to do in borderline findings. I think we can go on and discuss this forever, because it's interesting and it is challenging, and it is something that plagues us every day. I thank the audience also for a lot of interaction, and Dr. Renuka has interacted earlier also and now also. Thank you so much. And I hand it over to the conveners. Extremely grateful to my panelists, Dr. Manisha, Dr. Preeti, Dr. Revati, Dr. Saira, Dr. Nivedita. Thank you so much for making it also interactive.
Thank you so much, ma'am, for the opportunity. Thank you,
Thank you,
TNFOG, as well as
Thank you.
thanks,
Thank you.
Madhumita.
Thank you, ma'am.
Thank you.
Thank you. Thank you so much for the excellent
Yes, sir.
panel, dear Chinmay ma'am and our respected panelists.
Madhumita, only 1 minute.
Yes, ma'am. Yes, ma'am.
Chinmay, how are you doing this panel? Really, I am. This is the third time I think we are making a Chinmay in the panel. How interestingly she is making it. And only one take-home message for the obstetrician. We should be in a position to when to refer the case to the fetal medicine people. We should not hesitate to refer the patient to the fetal medicine people. Thank you, Chinmay. Really great.
Thank you, ma'am. Thank you for the opportunity.
My throat is not good. That's the reason I am so quiet.
No, ma'am. Get well soon. We need you to talk louder.
Yes. So we have vote of thanks by Pradanya ma'am. Yes.
Yeah, I think I would like to thank Dr. Sampath Kumari ma'am for envisioning this association between AMOGS and TNFOG. And I think it was such a wonderful webinar. I would like to thank all our chairpersons, speakers, and panelists today. And I think I would like to also thank Dr. Madhumita for being such a great coordinator and for doing so many things last moment and making this webinar such a success. And definitely Shield Connect for helping us going through this webinar today.
Thank you. Thank you.
Thank you so much, Pradanya ma'am. Thank you. Ma'am.
Thank you. Thank you.
Thank you, everyone. Thank you, Shivan.
Thank you all.
Good night.
Good night, ma'am.